Hello and welcome to the last and probably best session of the day. Thank you for agreeing with that. We are going to be talking about diverse data, health inequalities, genomic health equity. I appreciate that some of you may have been here all day or you've come in especially for this session. So grab a cup of tea, or because it's so late in the day, your G&T. No one's here to judge. Sit back, relax, get really involved in this meaty discussion. It's an absolute honour to be here in 3D. It's nice to be able to kind of see and smell and touch all the panelists. Smiling in a good way. You're looking really nervous, Sofiane, there. We've got a panelist for a really varied background, lots of different disciplines, clinical, ethics, anthropology, research, and so be prepared for a very, very diverse discussion. I'm going to take chair's privilege to give us a lay of the land, but before that I just want to kind of introduce who I am. So I am Maxine McIntosh. I'm the programme lead for diverse data at Genomics England. We're a programme that aims to ensure that genomic medicine works for everyone, and I'll give you a wee bit of detail a bit later in terms of how we're kind of delivering on that ambitious goal. So obviously, we have a long-standing history and problem with diversity in medical sciences. So science has been colonised by weird countries, Western, educated, industrialised, rich and democratic countries. It's a quite useful acronym if you want to just lump all of those countries in one. And in a world where our research and our lives and our clinical practice is increasingly being driven by data-driven systems, we have to be very cognizant of some of the solutions we're building on the back of potentially imbalanced and biased data sets. And this, in the context of genomics, can impact everything from misdiagnosis and understanding human biology to understanding human history. And we really have ended up in a position where not all clinical insights are equally as accurate or applicable to every single type of person. Just a few statistics to see how far we've come, or how little we've come, is maybe a better way of putting it. In 2009, only 4% of precision medicine studies had individuals from non-European ancestries. And this has improved to 19%, which was a figure from 2019. And this is largely dominated by an increase in individuals of Asian ancestry, but still far behind where we should be from a global context. We've had loads of efforts in different ways over different years addressing this, things like H3 Africa or All of Us, but still we could do a lot better. Now, the slight challenge with all of this is that it's not simply as easy as increasing the number of people of different types of backgrounds in data sets. It's a much bigger problem. It's a structural problem. You've got things like the funding that determines what sorts of questions the research community poses. We've got the poor diversity amongst the actual researchers and clinicians in the sector working on these problems. We've got groups who've been historically excluded and today still excluded. We've got challenges like preferred cohort effect, i.e. it's just easier to work on the data sets that we've already and always used. And it's important to say that this is not just a genomic challenge, this is a challenge across almost all of health data. But genomics has a specifically challenging problem that certainly in the past and in many places around the world and on our home turf today, genomics has been used to justify particular abuses, particularly in eugenics. So it's a complicated problem. And our programme is going to try as hard as it can to make a tiny dent in what is a massive global challenge. And so we're doing this kind of through three main ways. So one is we're putting our hat in the ring to increase the number of individuals from underrepresented backgrounds in genomic data sets. So we're really pleased to be partnering with Born in Bradford in the first instance, who are a cohort who have many more individuals from a Pakistani background in them. Secondly, we're looking at working with different types of community groups, grassroots organisations, through novel community engagement activities. And lastly, we're cognizant of the fact that increasing the number of individuals and data sets through specific sequencing activities may take a wee bit of time. And there's a lot we can use in terms of the current tooling or statistical methods or even behaviour change right now to make sure current insights with practitioners are as fair as possible. Obviously, collaboration is a really important thing for this, and I think we all recognise we need to work together to raise a very, very low bar when it comes to health data equity. So that's been a pretty long spiel from me, and we have a ebullient panel to my left, some of whom have come not very far, and some of whom have come very far, so thank you very much for travelling all the way down to London, Sofiane. So before we kick off, one of the things that has become very clear is, and I've said it numerous times, I've talked about diversity, I've talked about underrepresented groups, and I haven't talked about who those people actually are. And what transpires is that we've got a very varied, not just in this room, all over the place, we've got a very varied definition of what we actually mean by diversity. And I really hope that none of you agree with your points when I ask you what that is now. We've got genomic diversity, ancestral diversity, environmental diversity, and wider socio-cultural factors. So what I'm going to do is I'm going to kick off by asking each of my panel to introduce themselves and also define what you mean by health data diversity, why you think it's a challenge, and what you're doing in your work to address that. Sofiane.
Great.
Given that we've come so much far, you
Yes.
can be the first one.
I can. So we're doing all the questions.
Go for all of them.
Okay, great.
Defining diversity, why it's a
Yes.
difficult challenge, what are you doing to address it?
Fantastic. So my name is Sufyan Abid Dogra. I am an anthropologist by background, and I work as a senior research fellow in this longitudinal birth cohort based in Bradford. We call it Born in Bradford. Between 2007 to 2011, around 11,500 mothers, pregnant mothers, were recruited in this study, those who gave birth during this time frame. And now we have almost 14,000 of children and families where we have genetics data and health information, and we are tracking the health of these children and young people who are turning into young people now, because our first child this year is going to be 13, which actually for us is a journey into age of wonder. So we are trying to understand what are the causes of ill health and what are the causes of good health, and how they are linked across ethnicity, in deprived neighborhoods, and in kind of different communities with different historical, cultural, social, socioeconomic background. So that's what we do. And in terms of what is diversity in relation to genomics, for me it would be, we are talking about England and Wales here, for example, then it should be, the data should be reflective of that. And as long as that is the case, I think we will ensure and we will have genomic diversity in our data set and in our knowledge production. Now, diversity is not only numbers in data. For example, you have 500,000 sample, and then you proportionally kind of have all ethnicities according to their population numbers. But that won't be diversity. It will be diversity if that data, when collected, when compiled, when transcribed, when translated, and when disseminated, reflect the same diversity. Otherwise, it's just a boring data set saved in some supercomputer and some big boss is running it. It has to kind of answer the question in the complications of lives of people that are linked with their kind of genetic health. And if it does not answer those questions, then it is not a diverse data set. At the same time, if, for example, this data set, when it starts informing and educating and kind of disseminating, it kind of ends up compromising different identities, although it is talking about every identity within that data set, and then somehow certain identities become superior or better or good health genetic makeup on the cost of other identities being born with defects. And then again, that data set in the process of knowledge production is not diverse. Rather, it is very linear and, as you said, very much weird. Now, that weirdness of, in abbreviation sense, of data set is a huge, massive problem and a challenge. And this is the biggest challenge we are facing in this field of knowledge production. So the second part of the question is what we are doing. So in Bradford, we have this fantastic and in a way very unique data set where we have almost 45% of South Asian population, which is kind of reflective of Bradford city's population. And then we have majority white British population and their samples, those children and mothers. And we learned a lot of things through our data, that how benefits of health are unequally distributed. And the benefits of health are there, and everybody can have, theoretically can have access and get benefit from them. But when it comes to actual practice, it doesn't happen. So what we have done in terms of data and health and genes, we kind of try to understand what are the kind of socio-economic, historical, and environmental factors that shape the genetic health and that define the genetic health of certain population groups. We also kind of learned what is the relationship of age, and particularly age of mother, with the chances or likelihood of children born with any genetic disorder. So these were the contribution that we have made in the knowledge production on genes and health. And our plus point has been, Bonnie Bradford has been champion of diversity in that regards. The challenge that we face is how general public perceives it. So the moment when we start talking about genes and health, and then suddenly the genes become political, and they are charged politically, and they are spoken, discussed, disseminated, and translated politically. And people with their biases and xenophobia, and people with their whole kind of, sometimes in some cases, bigotry, then they start defining it as it suits their political agendas. That has been a big challenge. For example, when we talk about consanguineous, am I pronouncing it right? This is the word
I am, but I'm going to give you 20 seconds until we move on to Natalie.
So the media will suddenly have all its cameras on it, and they'll be like, oh, you see, the causes of ill health are in the marital practices. But that is only a tiny kind of proportion compared to the bigger picture, which is 19% of children born with the recessive disorder or other genetic health problems will be from the females who are giving birth after the age of 34. And of course, that reflects another population group. And that's a bigger issue which no mainstream media will be talking about. And then that, again, when people listen, media talking about, like, for example, cultural groups listen, media talking about them in a certain way, then they are not happy and they think science is their enemy, which is exactly opposite message that us researchers, academics, and people in data are trying to give. That science is here to benefit people and improve their lives. I will shut up.
Sofiane has done an excellent full tour of all the problems and solutions. Thanks. You got us covered. I don't even need to be there. Yeah, we should just go.
I'm going to get my train back.
No, thank you so much, Sofiane. I think the example you gave around consanguinity in South Asian families and the proportion of children born of women who are over the age of 34, I think is such a good example of the lens we take on certain types of questions that we maybe bias when we're looking at genomic research. Yep. Natalie, do you want to remind of the question? How you define data diversity, why it's a problem and a challenge, and what you're doing to address it?
Right, fantastic. Thank you very much, Maxine. So I'm Natalie Banner. I lead understanding patient data, and our aim is to try and make the way that health data is used a bit more visible for people, more understandable and more trustworthy. So our focus is on the way that routinely collected health data can be used for purposes beyond care. And this question around diversity is hugely important for the reasons that both you and Sofiane have outlined. But I think that when we think about diversity in data, it's really important not just to focus on the kind of qualities of the data sets themselves. Because I think if we focus solely on what's in the data, as it were, we can tend to think of it as being quite static, as something that's sort of just there, it's sort of monolithic. And actually, data is very dynamic. If you zoom out a little bit and think about diversity in the context of the collection of the data and how it's being used, then you get a much more complex question. And of course, I'm adding complexity to something that is already a complex problem. So if you zoom out a little and think about diversity in terms of, well, let's start with what's collected. What information is being collected, what's not? Is what we're counting all that counts? Are there things beyond what qualities we have in the data sets that are collected and that exist themselves that might matter? So there's big questions there around the sort of the diversity, the questions we're asking when we're collecting data in the first place. But then you think about the analysis of that data. Well, who's analysing that data? What assumptions are they bringing to that data? What proxies are they using for maybe certain characteristics? And in saying that there are assumptions there, that's not necessarily a criticism, because of course we all have to make assumptions when analysing and using data, whether we're talking different statistical models or other things. We are making assumptions all the time, but of course those things might be implicit. We might not realise that those assumptions are in there. So we have to ask questions about who's analysing that data, what are they doing, what kind of questions are they asking? And then further on from there, are we thinking about the sorts of the tools that might be developed off the back of that data, the software, the algorithms, and so on, and how are they going to be deployed, for example, in clinical practice? And once you start thinking about that entire life cycle of data, these questions of diversity, I think, become much more challenging, much more prominent, but they go beyond, is there bias in the data set? Because there's, of course, that entire life cycle to consider when thinking about diversity. Now, one of the challenges of thinking about that much bigger picture and that more holistic perspective on questions of diversity in data is you can end up getting paralyzed quite easily, right? Because you just think,
I feel seen,
wow.
I feel seen.
Yeah, you think, in order to resolve any of this, in order to do a meaningful analysis of this data or to use it in a good way or to develop a good machine learning model, I have to solve structural inequality and eliminate systemic racism, and you can just feel very stuck. So I think it's really important to be able to highlight that these are challenging questions, but it doesn't mean that it's impossible to move forward, because even becoming aware of some of these, the values that you might be bringing to an analysis, or that there might be the questions that you're asking might not actually be helping the communities that you're looking to serve when you're analysing and using data. Even just becoming aware of those things is a starting point. So I suppose my answer to the, why is this an important problem to address, is surfacing it and recognising that you can't necessarily solve for everything, or eliminate all of these biases is the starting point. In terms of what we're doing about it, understanding patient data, one of the things we saw during the pandemic was just the serious disparities in morbidity and mortality for ethnic minority groups compared to the white population in terms of COVID. But something that really struck us when we were looking at some of this data was actually how much is kind of missing. So I think one of the Open Safely studies that looked at COVID morbidity and mortality, that looked across primary health records, across the population, millions of records, there was something like 26% didn't have any coding for ethnicity. There was just nothing there, right? So that is a massive amount of data that we're just not collecting and not getting. The policy response to this challenge has tended to be, we need more data. Let's get more data. We need to improve the collection of ethnicity data. Let's just go ahead and do that. Tick that box, exactly, Sufyan. But actually what hasn't been done so far, and what we're trying to do at understanding patient data, is step back and say, well, have we considered maybe exploring with those populations, with particularly ethnic minority populations, what questions they might have around how this data is collected and why it's collected and what it's used for, rather than just assuming we must get more data, we must always get more data. So we're conducting a piece of work with Clearview Research, who specialise in peer engagement and community engagement, and they are working with members of the Black and South Asian communities across the UK to explore with them how they feel about the collection and use of their health data, with particular focus on ethnicity categorization and how they feel about those labels, whether they are in fact, being useful for them, whether they feel that actually research doesn't help benefit them in their life, so why on earth should they support the collection of this data? So that's a piece of work we're doing at the moment. It's kicking off right now, and we should be able to kind of report on that early in the new year. And from that work, we will then work with some health professionals as well to explore with them whether there are further questions that they hadn't really considered, drawing on this kind of deep peer community engagement work we're starting right now.
It's a good sort of tenterhook pitch for watching this space. Amazing.
Watch this space.
Dan.
Hello, I'm Dan. I'm a research...
What's your name and where do you come from?
I'm
Sorry,
a researcher.
I just
I disturb my flow.
Sorry.
I've got to start all over again now.
So
I'm a research bioinformatician at Genomics England. So I work with Maxine on some of this diversity work. In particular, my interest is around the genetics of this stuff. The conversation about diversity is something we've been having quite a lot in the office, and it's something that is quite nebulous and it is difficult to unpick. There's lots of different facets to it, as you guys have been enumerating. For example, I like to talk about genetically inferred ancestry. That's what I like, because we look at genes and we look at genetics, and that's what I will then try and infer, and that's how we try and do our analysis. But then that's different from self-reported ethnicity, because ethnicity isn't just your genes, it's it's your culture, your history, the way you've been brought up, your religion, all these things that do have an impact on your health as well. And then there's other elements like deprivation and so on. So yeah, it's difficult to try and define. Like I said, it is a bit nebulous. So if I try to just sort of maybe narrow down just to the genetics, because that's
so you don't get too existential and paralyzed with the problems, yeah.
Exactly. So yeah, I mean, at Genomics England, we're within the 100,000 genomes cohort, we're actually pretty representative of the UK population. If you look at the 2011 census, you find that really we captured the main groups in a pretty good way. With the caveat that, that's comparing self-reported ancestry data from the census to genetically inferred information. But then really, it's not good enough to just be representative. You have to do more. And that's because the numbers that we have currently don't allow us to have sufficient statistical power to do the analyses that we want to do. And so, we're looking at our data and we're looking at various different facets of it, and we're trying to understand, are we seeing that, for example, a question we want to know, a question we want to answer for is, do people have a different experience if they're from a different ancestral background? So does that mean that they are less likely to be a solved case? So somebody who's gone through the pipeline, and then we've been able to feed back to the clinician some kind of actionable finding. And that kind of question might at first seem very simple, but really it's completely mired in so many confounders, so many things that might be influencing this, that it's really difficult to answer. But these are important questions to have answers to, and the things that we want to try and focus on. So, how are we, what are the challenges, I guess, right? So one of the things with the genetics of it is, as has been said by everybody so far, everything has kind of been developed around this sort of white or Western European framework, and that means that our methods are geared to work in that way. And so, concretely, an example of genetics, the way that we sequence somebody means that we basically chop up, well, not the person's DNA, but we have all of these. No chopping occurs. We basically have lots of these millions of small reads that we have to kind of align to what's known as a reference genome. But the reference genome is largely European, and that means that we are missing entire chapters of this book that is our genome. And so a really interesting paper came out a couple of years ago showing that as a human, you have about 3 billion base pairs, and they sequenced an African cohort and showed that about 10% of that was missing from the reference genome that we have. So, really, really key information could be lost there. So the kind of things that we can do about that is try to identify the best methods to get past that. So whether that be building specific reference genomes for each subpopulation or superpopulation, or having some kind of consensus reference. But the actual solution we're not clear on, but it's important that we try and address that there is a problem there, and that we do something about that. Yeah. Anything else? What was the other question?
I mean,
what are you doing about it?
You've also covered. You guys are covering.
What are we doing about it? Yeah. Okay. So I mean, right now it's as I'm sure Maxine would attest, it's early days for diverse data within Genomics England as a program. So we're trying to get the lay of the land and really understand what the picture is already, because you can't start fixing stuff until you know what the issues are. And I think there's a lot of work going on with the team trying to identify where biases may exist throughout the process, not just at the genetic level, but other elements such as in the healthcare records and the methods that we're applying, all that kind of stuff. So it's, like I said, early days for diverse data. So that's what we're trying to do is build the best picture possible.
Yeah, and certainly in the early days of just cutting the data and looking at where different protected characteristics might intersect, it's showing how complicated the story is. And I know you gave the example of ethnicity and deprivation, but it's a really messy picture to work out exactly what do we mean by underrepresented in our own data. It's taking us a long time to even get that out. Harpreet, last but not least, it better be good.
Last but not least, I'm not sure how much I have to say, but I do think there's a few things I would like to bring up. So I'm Harpreet. I'm kind of wearing three hats. I'm a GP in London. I sit on the board of Health Education England, which is a national agency that is responsible for the training and education of our workforce in the NHS. And then the third hat is I'm co-chair of the data and digital workstream at the NHS Race Observatory. So a lot of the things that we're thinking about and talking about today are relevant to that. And actually, over the last 9 months or so, I've been working as a clinical advisor to the vaccine program. So how we drive up the uptake of vaccine in underrepresented communities. And so a lot of kind of learnings from there, which I think are applicable to our conversation today. So I just wanted to build on what colleagues have said on the panel. I think one of the areas from the data diversity angle is that I think the what is important, the how is important, but I also think where the data is collected is also important. And so what I mean by that is essentially in healthcare, we see, health and social care, we see primary care, secondary care, mental health, community health, and I think each of those areas, data is collected in a very different way. And that probably leads to many of the inconsistencies that we're talking about, especially when it comes to ethnicity coding. And I think, it was talked about, it may well be a tick box exercise, but I think it's a really important tick box exercise because we do have quite a rich set of data in primary care, for example, but it's very hard to pinpoint that on ethnicity. And if we started collecting ethnicity data more, then we can actually then do some useful work with it. But I think for me, the really important part is when we come to the challenges of it is how do we apply this in a real world setting? Now, as a GP, as a clinician, I do really struggle with the genomics, genetics agenda because there's a paucity of understanding. At medical school, it was one of those lectures that you wouldn't want to go to because, it was all sorts of reasons.
Safe space, it's not like there are thousands of people watching
it just wasn't, in my personal experience, it wasn't very well taught. And, I think it's a complex area to really grasp. And I extrapolate that across the whole clinical community, and I think there's probably a big lack of understanding. That combined with the lack of understanding in the public, I think combines it with the issues of trust, perception, and all of that. It was interesting, I asked my mother this morning as I was coming on this panel, I said, what do you understand about genomics and your genetic data? She thought that it would require someone taking a knife, taking a biopsy of her skin and analysing that. And, she's quite well educated to some extent. But my point being that it's a very different perception of what people think. And unless we really start thinking across those lines, the challenges will still remain, as well as all the structural challenges that we talked about, which I think all fit as part of the picture. I also think that there's challenges in terms of how many people come forward for clinical trials. In terms of the research agenda, we see racial differences in drug discovery, but also with the age element, how many elderly people are coming forward for clinical trials versus young, fit and healthy. So I think that also plays a part in the challenges we have with data diversity. In terms of what we're doing about it, and I think with the 3 hats I mentioned, from my GP hat, I've been helping set a clinical trial up in my primary care community in order to engage more with the primary care side of things, encourage to get more people closer to their homes in the community to understand why this matters rather than relying on big academic, prestigious hospitals, because people are afraid of those and people don't want to engage with those, whereas they do want to engage with their GP practice. From the race observatory, a big focus for us is the ethnicity coding. So how do we actually make that consistent throughout all the different areas of record keeping so that we can then join the records up, we can have a true longitudinal record. And then from the HE perspective, there's a big focus on the skills and training part. So from a genomics angle, Health Education England sponsors the Masters in Genomics, but I think this needs to spread wider than just doctors. We need to think about nursing, allied health professionals and all the other undergrad, postgrad. So there's a big piece of work that's being thought through on that element. So I will stop there, but hopefully that gives you a flavour of what we're doing.
Amazing, thank you. I think the mum test is quite a good one. Quite often when we're not sure about something at GEL, our team were like, well, we asked our mum, and this is the insert quite a specific mum response. So I quite like the mum test as a barometer. Yeah. So just, we've already got some questions coming in. I just want to remind you that we're on social media, hashtag GE Innovation21, and also to keep your questions coming in. There's no such thing as a stupid question, just knobheads who make you feel stupid, and we are not going to be that. So please make sure you ask your question, however extensive and scientific and technical or not it is, all are welcome. So there's a couple of things that have come up that I want to just double down on that also reflects a question that's come in around categories. So one question's come in from Varun Kumar, which is around the categories of ethnic groups and the categorization that we have in the UK. And it's building on something that Natalie said about the dynamic nature of data and the fact that actually our ethnicity and our cultural identity and how we feel on the day, depending on who you are, might very much change. And also, it might not necessarily capture the things that define how you behave. And I know this is something that you've looked at extensively. So how do we marry up the fact that we've got really big questions about cultural identity with the fact that we've got the reality of we have to monitor stuff, we have to collect stuff, we have to get a lay of the land, and that requires us to have some structured forms with some labels. So in the context of genomics, we overlay an extra level of complexity with the fact that we have a scientific definition of ancestry. Mm-hmm. So how do we marry up culture, ethnicity, ancestry?
Well, go on. No, well, I was going to start by saying, I think it's really important to understand what the purpose is, right? Because if you have the purpose right and where this is all going, it really matters. I mean, many of you may have come across this, but when I was coding the other day on the vaccine program, and the Dropbox said mixed other, right? I mean, for many people, right, you've got your white, Caucasian, black, Asian, British, etc. And you've got mixed other. I mean, who fits in mixed other? I don't know. But if you ask someone, but my point being, my point being that for the individual, my point being for the individual though, it's like, I've got an ethnicity, this is, but I can't capture that. So my point being that unless we're clear on the purpose, is it for research, is it for actually, applicability in the clinical setting, I think that needs to be clear. And I don't personally believe we are clear on that as an ecosystem. I think we could be doing more on that.
If I may. So we are human beings and we live 70, 80, 90 years as average and then leave this world. But genes are ancient. They have a long age that goes thousands of years back. What we learned in our recent study that, so 7 or 5 years ago at Bourne in Bradford, we conducted this research on, kind of marital practices and childbirth and how it shapes our genetic makeup and what kind of recessive disorders we have under certain kind of variables and conditions. But then we learned also each ethnic group has a distinct population effect. Now, that was a new concept for me because I am the non-sciencey doctor here, Doctor Who. And I kind of got interested in learning more about it, how we capture the population effect of different communities, cultures, and people from diverse background. And this was fascinating. Each community or each geographical human group have kind of developed their bodily kind of genetic makeup under the influence of a variety of environmental conditions. I'm a migrant, I'm from Pakistani background, but in India and Pakistan, people are socially there are hierarchies and castes and how people kind of define themselves and clans and biradaris, and based on that, how people kind of, make their identity and then use it for political, social purposes. We learned it's fascinating how marriages or how kind of family composition changed altogether over the period of 2,000 years. So this is a research that we have along with scientists from University of Cambridge and Leeds University and Bourne in Bradford. We are going to publish in Nature Communications. We learned that 2,000 years ago in South Asia, broader South Asia, there were castes and people might be having all those professional occupational identities, but marriages were not within castes. Everybody was marrying everybody in the generic sense, not that in a open relation sense. But the point is there was no caste barrier to marry from within one caste. Down the line, around kind of 1200, 1000 years back, suddenly the genetic kind of analysis informs us, and people like Data Dan are absolutely, our kind of data administrator is also
I'm
Dan.
using that after
data. So our Bourne in Bradford person who managed this big machine of data is also Dan, and we call him Data Dan.
We were all...
That's it.
And we need to kind of, So when we got that data and kind of, we learned that down the line, around 1,000, 1,200 years ago, what happened suddenly, people in South Asia and India and Pakistan, they started to kind of marrying within certain clans. And then down the line, 300, 400 years ago, we learned that certain clans have more kind of intermarriages, and they happen to be upper caste during Mughal Empire. So we saw Mughal preserve their kind of imperialism, and then local Rajputs copied the same kind of way. But something strange happened during British Raj, and that was interesting. So
a lot of things strange happened.
So that was something which was fascinating. We learned that,
You better answer my question at the end of this story, by the way.
Absolutely, and story is very important to answer that question. Otherwise, there'll be boring answer. So during British Raj, what happened that property and revenue laws were changed. As a result, my property will be transferred to my children and sons back in the days, and then to their sons and to their sons. And that means the first casualty of that property laws that were introduced to collect more revenue, the first casualty of that was women emancipation in South Asia. So men thought, okay, if women marry within the family, the land stays within the family. So land and women were kind of equated, but that significantly shaped our genetic makeup and how kind of the diversity of genes within South Asian communities, they were like, yeah, kind of compromised significantly. Now, after that, what happened is that we learned that people organize themselves on clans and brotherries, and we learned, okay, if we kind of collect data, and connect family and culture and ethnicity, and look at the person straight away, it would not make sense. The historical population effect need to be understood in more details, which means we will have to go back and see whether grandparents are related or not. We will have to go back even further and see what was happening 1,000 years ago and how this person's kind of DNA is evolving. So that kind of knowledge and education on genes and health is the way forward. What we learned is that when we kind of focus on individual and forget about the context, it does not help very much. And this applies to all ethnicities. And by the way, we live in this country and everything is kind of, fluid identities and everything. But somehow, strangely, when it comes to ethnicity, it's never perceived as fluid. It's perceived as identified through color of skin because we live in a kind of racialized, post-racialized society. So ethnicity is very much fluid. At the same time, it's not kind of...
if I could pick up on that. So, I mean, yeah, what you say is interesting in that, often you would think, right, black describes an ethnicity, right? But I mean, it doesn't. But you would still see that as a way of describing people. Yeah. And then, if somebody said to me oh, we've got a cohort of black people, I'd say, well, that's meaningless. What does that mean, right? You don't sequence black people. You sequence people from certain areas, and that is what's going to allow you to ask interesting questions. Mm-hmm. And, as Maxine said, right, I'm a mixed other, right? That doesn't mean anything. What is that? I don't have anything better to put in right? And so, if I'm self-reporting ethnicity, I'm probably just going to say, right, well, that's just a bit of an awkward bin. I'm probably not going to look at that. Yeah. And then, you're just going to start ignoring some data because it's not it doesn't fit into a nice box. It's not easy to kind of try and marry other features to that to try and build a more complete picture. So yes, things need to change. The one that I was actually really alarmed about the other day, I had a day 2 PCR test. I was very fortunate to be on holiday recently. And on the ethnicity thing, the option that I had to pick was white and Caucasian. And I was just like, oh, I didn't understand why Caucasian was an acceptable term to be using at that point. But yeah.
When data down becomes missing data down, we've got a problem, I guess.
Yes.
So there's, and I just want to, I'm not going to pose this as a question because I think it's just a very good challenge, but it's a question from Ava. It says, what's the value of extrapolating ethnicity genetic group when there is no clear biological or genetic racial population? How will your push for diversity not merely extend biological perceptions of race, i.e. racism? So I think we've kind of touched a little bit on that, but I think that's a very, very good provocation.
Yeah. I just wanted to follow in that, there is no biological basis for race, right? Yes. So, that's just kind of a very uncontroversial statement within biology. There is no such thing. What people would use to describe race are things that don't really relate to your biology. Yeah. It's not part of this conversation.
Just adding on that, we are one race, human being. And then, of course, what we kind of differentiate with each other is based on the color of skin, but we are one race. And that has to be part of mainstream perception that we human beings are one race, and that defines our biology.
Absolutely. I think there's a very important point, though, that goes back to Harpreet's, which is the purpose has to be very clear. And whilst I agree with the sentiment you've just expressed, the disparity in COVID outcomes is a good example that in order to understand why we had a disparity in outcomes that was seemingly emerging based on ethnic groups. In order to dig down to understand, is there a genetic mechanism, is it social determinants of health, we had to go and collect some of that data as a starting point. So I know that Natty's involved in an initiative called People Like You, and we went to a conference last week which was talking about the increasing personalisation of data. And as you become more and more granular in defining someone, you hyper-personalise, you depersonalise someone because you break them down into their constituent parts. So I guess there's a kind of fine line between defining someone based on categories and then going too far that you actually lose what it is about them. But the purpose of collecting that data, I think, is a really important starting point to allow us to get to a utopia where we are all one race, one family, not in the polyamorous open relationship marrying sense, just to be clear. Good, yeah. So gear change, I wanted to pull on something that Harpreet said, and I know that Natty's been very involved in, and it's this idea of kind of genomic exceptionalism. Like, why is genetics any more special or different to other forms of health data out there? And I do think there are some things that make this area of science more unique, but there's also lots of things that we can take from other areas. So I wanted to particularly start with you two. What can we take from vaccine uptake work and vaccine hesitancy work for informing how we want to engage in different types of people in their populations for genomic engagement? I think this question has also come in from someone in the audience, and also when you, in your work, looking at sort of most other forms of health data at UPD, and particularly things like electronic health records, do you feel that genomic data is any different based on all you've done in the last few years? So what can we steal from people who've already done a lot of work on this, basically, is the question.
Yeah, no, it's a good question. And, for me, it was quite eye-opening in terms of, a lot of the work that has been done, for example, in vaccine hesitancy, and obviously that's come to the surface of it over the last 15 months. It's more, we'd have a lot of armchair experts now. But my point being that it's really well thought out space. But if I can use an analogy, which is kind of the WHO model of the 3 Cs, right, which is often helps to overcome the hesitancy. The 3 Cs standing for the first one being around convenience. So how do we ensure what you're offering is accessible, it's physically accessible, but also from a kind of language, literacy, all that kind of understanding, so that people are really aware of that it's convenient, it's open at all hours, and all that kind of stuff that we did with the vaccine program. So that's convenience is the first C. The second is confidence, and I think that's really important in terms of the trust element. And so, the NHS spent a lot of time building relationships with community leaders, faith leaders, trusted individuals, using different channels of communication for different people from different backgrounds, different ages, and so on and so forth. And I think that was a really useful learning, because not only has that really understood that there was some level of paucity of how well we were doing in the health system, but I think that opens up a broader set of opportunities when we think about prevention, well-being, and how we can engage with communities more, because I don't frankly believe that the NHS was doing as well as it could have done. And the third is complacency, which is not as relevant, but that essentially stands for, from a vaccine hesitancy perspective, that this won't happen to me, so I don't need to take the vaccine, I'll be okay, kind of thing. But if we take the first two around confidence and convenience, I think there's a lot there that we can learn. And I think, like I said, the understanding of it, the people's perception of it, the trust element of it plays a critical part, and that requires constant engagement, it requires constant communication, it requires simplifying messages so that people understand the benefit, people are aware, but it also requires time to listen, right? This is not just about one-way dialogue, it has to be two-way. And that's where I think the GPs, healthcare professionals that were doing the vaccine program spent a lot of time doing, and they're still doing, and I think we have a lot to learn from there.
Is genomic data any special? Do we need to get off our little ivory tower of thinking we're unique?
In one sense, yes, and in one sense, no. So in the sense of yes, it's interesting when I try to describe to people what I do and what I work on, and I might make reference to sort of health data, and that might include genomics. People are, oh, so you're doing like Gattaca prevention then? They're just like, you're trying to stop that dystopic future, because the perception of genomics might well be that that's the direction it's heading in, right? Or that's the potential. And to be fair, that's not an entirely ill-formed view based on the history of eugenics. It's not as though that's something that's entirely unreasonable to be worried about. But on the other hand, certainly we've found when you engage and talk to people about the use of health data, routine health data, and questions about genomics might come up. Actually, the sorts of questions and concerns and issues that arise are fairly similar. People want to know, what's this data being used for? How's it being protected, both in terms of my own privacy, but also in terms of any societal risks and harms or risks of discrimination against groups? How are we going to ensure that the benefits are actually coming back to patients and to the healthcare system? So those are the sorts of questions that come up all the time with regard to routine health data that apply just as much to questions in genomics. So I think, broadly speaking, once you start to engage with, and it comes back to Harpreet's point about the two-way dialogue, really exploring the kind of questions that people might have, give them information, give them an opportunity to ask questions, to scrutinise, to challenge, then actually the sorts of issues that come up are very, very similar. And certainly we found that even if you're trying to explain and convey the potential benefits and the advantages and the way that safeguards operate, there's legitimate challenge and question there. Are you sure that the data is going to be used in that way? How safe can it be? Can you ensure that it is not going to be used for all these purposes you say it's not going to be used for? What are the assurances there? How can we scrutinise and challenge and check? Where's the accountability? All of those questions, I think, apply just as much. And the difficulty we have, I think, at the moment, certainly in the health data space, is that people feel there's good reasons not to trust what's going on. We've had the GP data debacle very recently, where it was certainly felt as though for all of the articulation of, well, here's what the data's for and how it's going to be used and how it's protected, people responded with, I just don't believe you. I think this data is going to be exploited. I don't believe that the rules that you're setting out here are going to be upheld. So I see a lot of parallels in terms of the risks and the issues around genetic data with health data more broadly. I suppose the one thing that I would say seems to create an additional concern is just that sort of the future orientation of genomics and the risk that it might be used to discriminate or harm some people or benefit some at the expense of others.
Yeah, and I know that's something you've talked about a lot in terms of closing the research loop, making sure the questions that certain populations care about are the ones that are being asked, and that's being fed and communicated well in a consistent way.
I think whenever we disseminate any analysis of data from genes and health point of view, then somehow mainstream media will always narrow it down to family and culture and ethnicity, which kills the whole purpose of disseminating the message of health and its relationship with genes. What we have learned is that we need to kind of talk about genes and health more and more with young people, with children in schools, and that's what we plan to do in future through Born in Bradford, next upcoming birth cohort of 30,000 young people. But what happens is that when we say this health issue is because of the family or because of the culture or because of the ethnicity, then we shut that door of kind of somebody willing to give you data. Then we create those conditions in which trust is gone. Then we come up with a language that does not help communicate the message. And I mean, just one tiny example is how convenient we say COVID vaccine hesitancy and suddenly the relationship goes to ethnic minority. As if people in ethnic minority background are hesitant to save the lives of their loved ones. But for everything else, we use the term uptake. And whenever all the health interventions or vaccines or medicine that's given to majority population, it is spoken through the language of uptake and never hesitancy. Funnily speaking, in London, in this fantastic city, when there was all the people who were anti-masks, anti-vaccine, anti-this, anti-lockdown, anti-social distancing, they were coming in thousands and they created a mess. I was looking at those images on TV and I was like, wow, those people down in London, they are like more kind of hardcore when it comes to kind of define the law. But I then looked at how they looked like. And somehow those people who were, in inverted commas, vaccine hesitant were not happen to be like ethnic minorities. And they are never informed or talked about as kind of hesitancy. The other problem with this kind of language is, okay, we say vaccine hesitancy, and then suddenly experts, and particularly, no offense, but medical experts coming, obesity is linked with prevalence of vaccine positivity. What is obesity? It is not linked. it is correlated. Obesity in itself is a reflection. I was just speaking with one of your colleagues before coming around this topic as well. Obesity is a reflection of 2,000 things going wrong back in the context, in environment, in structure. And those things are directly linked with COVID positivity and not the obesity. Suddenly, when we say obesity, we identify majority of working class people somehow because of how they look, how they appear, and what environment have created conditions in which their bodies look in a certain way. That is the reason for COVID positivity. So kind of these correlations which are like imaginary in a sense, because there is no real reasoning for that. We ignore those correlations which are real, like environmental structural factors, like food habits, like green space, like, a conducive environment in which children and families can go out and eat healthy and spend healthy time and create those conditions in which they can grow up happy and healthy. Instead of talking about those real things, we talk about, things like obesity and COVID hesitancy.
I think you raised very important points about the kind of multifactorial nature of what contributes to health and the fact we have to really recognise genetics in the context of that. Have you got a finger up or are you just tweaking?
I don't know if to put a whole hand up or just like a little,
go for it,
subtle.
Go.
I think the point about sort of ethnic minorities and vaccine hesitancy is an interesting one, and it was clear that
on track as well of the theme of the panel.
Yes, it was clear that there was a point at which uptake in those communities was lagging, but research from King's College would indicate that a large part of the reason for that is because the way it was being communicated to them wasn't culturally relevant. Right, so this is the problem of kind of like one size fits all like health policy and messaging, is that for communities that have different ethnic backgrounds, different language structures, their understanding of certain concepts might actually be different. And one of the major findings is just like the actual, the notion of risk is actually very different within a Bengali community than it would be within, like a Western European community. And also things such as, saying like, okay, well, look, you got to bubble and you're allowed to see like your core family. Well, core family can be a very different thing if you're from a South Asian community where family can include, your aunties and uncles and all this kind of thing. So actually kind of one of the things that really helped with that was, as you were saying, was its engagement with community leaders, people who have, deep knowledge of the communities from which they are a part, and changing the messaging so that actually we're not just translating words, we're also like translating the meaning.
Yeah. Just wanted to quickly pick up on the point around whether genomics data is seen as kind of exceptionalism and it's different to other. And I think the reason why that may be perceived to be like that is partly because where it sits and its relevance of it, because you've got all the data that we have in healthcare, then you've got genomics data here somewhere, and it's never quite linked up with day-to-day practice clinical work. So I think that there's a big undertaking there that needs to be taken. And the second is, who's the champion advocate that's protecting it or helping patients understand it? You use a great example of the GP data issue that we had, and essentially it was the GPs that were speaking up on behalf of their patients. I think it's very hard for GPs to speak on behalf of genomics data because they're not very involved with it at the moment. And so there needs to be a much more grounding on how do we then interact and intersect there so that we do have advocates, we do have people who are trusted. But ultimately, because this is all patient data, but regardless of us saying that, patients always end up coming to the GPs to get their advice. And I think there's a missing link there.
I think what ties actually a lot of these points together, and there's a question that's come in from Luca, which again I'm going to be rude and actually make it more of a point because I think it's a good point. On the point of multifactoriality, that's not one to say after you've had a few GNTs. Not that we've had GNTs, but you probably have in the audience. With increasing inequalities, we will expect an increase in health inequalities. Is the increasing recourse to GWAS study and polygenic risk scores shifting responsibilities of health inequalities from society as a whole to the individual or even ethnic groups? So I think that that's quite a nice way to tie in the challenge of if we're thinking about social determinants of health, we're thinking about communication. What does that mean for the individual in terms of the responsibility they should be taking? I'm going to bring us back to a question, this is going to be the last one from the audience before we kind of wrap up, about the science. Now, Data Dan, I'm not going to ask you to speak on behalf of all analysts everywhere, but
No, I can. I do that frequently.
good, yeah, good. But something that Natalie said, which is around how do people still don't believe that there'll be the quality control and there's the accountability, and people actually do it in the right way. And one of the big things that we're trying to think about in the diverse data program is how do we support a whole cohort of practitioners, be them researchers or clinicians, to change their behaviours and be more aware of the fact that the data sets and the insights they're receiving are probably going to be in some way biased. And on a day-to-day basis, you'll be making loads of decisions. There's loads in the pipeline, you're just a very important cog in it, but you'll be making loads of decisions which will shape the outcome of analysis. So there's a question that's come in to say, given that the current human reference genome is European-centric, there must need to be a large and vigorous quality control process when calling variants for other ancestries. How is this handled? So I wouldn't mind you painting a picture of, you're at your computer, like, how does an analysis work like this? And what are some of the decisions that you're making that you would hope other people could be more aware of? Because for some people who are prolific bioinformaticians, this is your bread and butter. But I think for many other people, they won't necessarily know what this entails.
Yeah.
Just a picture of you sitting at your laptop.
So I've got my headphones on.
Good, yeah. What kind of music do you listen to?
Great, coding music.
Multiple screens?
Oh, at least three.
3 screens.
Everything in dark mode. So, yeah, I mean, it is a difficult question. Yeah, we'll start with the basic principles first. So, okay, so let's say we've got the 100,000 Genomes project and we've got 80,000 people in there. They all come through as these individual files that says, right, this is where you are different from the reference genome. And then from that, what we do is we will merge these together because if you want to try and do research on it, having to look at 80,000 different files that have been, like, it's really challenging. So we put it all together, and then we go through quality control. And this is because you need to have some confidence that the variant you're looking at is real. There's a lot of things that can happen in sequencing and other things as well that mean that actually it would be a spurious variant, and you wouldn't want to try and link that to disease because that would be wrong. So you have to then try and say, right, these are the good variants and these are the bad variants. But the problem is that population and genetic ancestry does actually have an impact on that, because there'll be parts of the genome that are better represented in certain ancestries, or others where there will just be a higher degree of variation. And currently what we do is, for this data set, we do it across the board for everyone. It would be nice to be able to split that. I've actually literally been discussing this today to try and integrate bringing in the superpopulation. So in genetic ancestry, we tend to talk about 5 main populations. So we've got Europeans, East Asians, South Asians, East Asians, and American, which is a bit more of like a mixed group. And so the idea is that maybe what we can do is actually we can apply this site-QC to each of those populations individually, and then that gives you a better idea of whether you don't want to find that because we've got 70% of our data is European, you don't want to find that that's causing variants that actually are correct in the African subpopulation to be kicked out. So if you do it all separately, then it could give you an indication that that kind of the population structure is what is affecting that there.
I would listen to your Coursera.
Oh, excellent. Okay, cool. I'll set one up.
Perfect, thank you. I'm actually just going to take a question, but we've got a bit more time for one for the audience, around kind of innovative partnerships and working together and how to bring in different sectors. So the question is, how can charities and industry, et cetera, who fund medical research basically address this data diversity problem? And I think it'd be quite good to kind of attack this from lots of different angles. And so maybe we can start maybe on the engagement piece through innovative partnerships, if Harpreet, you want to kind of kick us off.
Yeah, absolutely. And I think, again, if I may use the example from the vaccine program, again, it was a real eye-opener in terms of where we were going and where a good proportion of the population spend their time. Just as an example, males under the age of 35 or in 40 actually, many of them don't engage with their GPs. Not many of them are coming forward. So where do they go, right? Football clubs, rugby clubs. So think about those kind of opportunities where you're creating these creative partnerships where certain cohorts of the population are going. Again, partnerships with religious institutions, right? Again, I'll use my parents as an example. My father got in touch last week and said, it's organ transplant week. I'm going to the Sikh temple to learn about organ transplant. But that's a good example of how we are using those setups where certain parts of the population are engaging. So this is not just about ethnicity, but it's also about age, and it's also about thinking different demographics and where do a lot of people spend their time. Within the NHS, for example, we developed a partnership with the Bangladeshi Restaurant Association, because a lot of people go to Indian takeaways, and there's a partnership there that we developed to engage the Bangladeshi population in the vaccine uptake. So my example there is being that we can't just go mainstream and hope that everyone reads BBC, The Times, The Telegraph. Actually, a lot of people don't read those, and there's a lot of people that read different things, different modalities, and engage in different ways, and we need to think about those creative partnerships.
Yeah, one thing you talk about quite a lot is making sure that we kind of go to where people are.
Right, exactly.
Hey, I went and had my smear test in a nail bar, which I think is just going to radically change my life.
And then that's a good example because
2 birds on stone, perfect manicure.
But that's a really good example, because in Africa there's good studies which show that people talk about healthcare in their hairdressers and when they're talking and getting their hair done. And I think we could be using similar examples here.
Yeah. So Natalie, your colleagues at the Wellcome, there's a lot of pennies sitting in Wellcome, and there are tiny, nuanced, minutiae decisions can move millions. And I know that something in the kind of digital equity and whole data science area is at Wellcome, you're kind of thinking a lot about actual funding and thinking about in the global context. Can you give us a sort of sneak peek in terms of the vibe at the moment, in terms of thinking about redressing the global imbalance on health data funding?
Sure, I can try. I do not necessarily speak for Wellcome, but one of the things around Wellcome's new strategy, and particularly what's happening in the Data for Science and Health team, is that we have a new strand of work called digital equity, which is really trying to, I guess, address some of these questions from the perspective of a funder. And the key rationale behind that team is to look at and take into account the needs of those who are developing, using, and affected by data science and digital tools. So that looks at those who might be developing machine learning models and using data to develop tools that might have an impact on health challenges that Wellcome cares about. It's about how those things are deployed and used in practice, particularly in clinical practice when it comes to health data, but also looking at how you can do sort of community engagement in a more robust and sustainable way, rather than seeing it as an add-on or a bit that you do at the end, kind of really building, thinking about who might be affected by the sorts of the data science that we're funding. And a key thing here is really trying to think quite carefully and critically about the sorts of communities that Wellcome has historically worked with, and maybe where we've missed things. So at the moment, it's pretty challenging to figure out how to explore relationships with potentially new grantees or new partners that Wellcome might work with. Because we have a sort of established set of structures and processes, and it's quite a big funder and so on, it can probably be pretty intimidating to think to work with different kinds of people. So in the team, we're thinking a lot about how to create more of an on-ramp, I guess, for different types of people to come and chat, to come and talk to us, to explore with us what work they're doing, and maybe whether Wellcome could provide support for that. Also just trying to look a lot more globally than Wellcome has historically. Wellcome has funded Africa and Asia programs. We've got very established centres in different areas, but actually what's the future of those? Are we going to be able to maybe explore working with different communities? We haven't done much work in Latin America, for example. So there's a lot of thought going into ways of trying to explore more what Wellcome could do, not just as a funder, but more of a kind of, I hate the term thought leader, but a bit more of a push, a strategic push to think, actually, if we care about these sorts of health challenges, particularly around climate and health, mental health and infectious disease, how can we ensure that the science that Wellcome is funding is going to benefit everyone? And that benefiting everyone bit is what we're trying to figure out. How do you go from a slogan? How do you go from a slogan about benefiting everyone to practically speaking, ensuring that the science that Wellcome is funding and what it's supporting isn't inadvertently causing harm, for one thing, but is actually going to have more of a beneficial effect across the communities that we care about. So very early days for that team. Wellcome is kind of in the process of trying to figure out exactly how it's going to implement this strategy. But I think the digital equity piece of that is going to be really exciting in the longer run.
Absolutely. Yeah, absolutely. I think that pulls in on a couple of questions and comments that come in around, focusing on digital equity or diversity or any permutation of these words. What do you run a risk of potentially causing more harm than good, or by kind of shining a lens on the specific challenge rather than maybe embedding it.
Yep.
So I think that's a good point. It's difficult to know whether to take one from the audience or to be really selfish and choose my own. Maybe I'll take one and then I'll bundle it. So there's a good point that's made that are there more diverse genetics projects planned in the UK? Because this person feels that when asked about genetics diversity projects, born in Bradford, excellent as you are, is often used as the example. Surely there are more and more is needed. So yes, there are more and more is needed. But I think that this raises a very good question, that one thing that we found in this really early stage of divining and designing the diverse data program is it feels like a very, very fragmented area of research, because you've got the algorithmic fairness community, you've got the population geneticists, you've got the health data ethicists, and everyone's kind of all linked, but it's not quite talking to one another. So you're not allowed to say born in Bradford, by the way, but if you had a kind of different example of a project or a piece of work that's looking at something to do with this whole space of data diversity that you would particularly want to say, I think these guys are legends, do you have one? You can start, as long as it's not born in Bradford.
I am not aware of any, I will be honest. Maybe...
It's not competition, but Dan seems to be...
Well, so like East London Genes and Health,
Yeah.
right, as an extension of Born in Bradford. Well, so that looks at other diverse communities within East London. But I mean, also, I think one of the things that's really great is that, following on from the example, I think, really of Genomics England, there are a number of different countries now that are setting up their own similar programs. And this is across the world, whether it's like Australia or Hong Kong. There's in the States, there's the All of Us program in the States, is a very big diversity initiative there. So I think people are really mobilizing and doing these large scale type projects where diversity is, it will emanate from that.
Yeah. And I think there's a big question about how we work internationally. I think one thing that's fairly unique about certainly the data that GEL has is its linked data to administrative data sets like clinical records, which lots of other countries may have done whole genome sequencing but don't have that data linkage. And to your point, I think that there are potential massive problems and risks if we continue to look at genomic information without additional context around social determinants of health and clinical information. So I think for us that's a real challenge in the program, that we want to be able to make use of all these international efforts, but if we don't have the same sort of data structures or linkage, or we're not framing it in the same way, it does make it a bit more challenging to collaborate. Doesn't necessarily have to be on genomic data diversity. Any other kind of interesting data diversity problems?
Well, I do want to pick up on one that is genomic data, which is the H3 Africa Consortium that you mentioned, the Human Heredity and Health Consortium in Africa, because there's more genetic diversity within Africa than there is across the rest of the world. And I think people often sort of think of Africa as a country. It's not, it's a continent. It is absolutely huge. And this is a very substantial consortium that Wellcome funded along with the NIH in the US. But that was really focused on developing capacity and leadership for genetic analysis within Africa. So I think that's kind of a nice example of something that was it was set up to try and avoid this problem of being extractive with data. This is not just people coming from the US and the UK extracting data from African populations, taking it away and doing analysis themselves and creating benefits for their own communities and populations, but it was very much focused on that really capacity building, those capacity building efforts in many of the countries across Africa. So that's the one I'd point to.
Yeah, we did start by saying how colonized the whole scientific landscape in this space is, and I think that's a good example. I'm going to just take opportunity of being the chair to answer one question from Taminda, which is, what checks are being put in place to ensure that ethnicity and other diversity metrics are built into study design and not an afterthought? Are these things being taken into account when accessing the GEL research environment? So work that Dan and I have been involved in, and it's being led by a fantastic designer in our team, Sophia Liu. She has done a thorough dissection of all the biases that exist within the GEL pipelines. Not to say that GEL is particularly bad, but I think if we were to apply the same method across many institutions in the world, I think we'd all come out, maybe being as less good as we could be when it comes to being a completely bias neutral space. And so one of the things is just finding small ways we can just nudge people's behaviours just to be a little bit better. So that could be when accessing the journal environment, or putting a proposal, or writing up your paper, to make sure that you've considered equity and diversity in the analysis of that. Or the bar we've realised is set very low just for basic awareness. So we're really hitting this at lots of different levels. It's not necessarily a fancy statistical model, whilst I think a fancy statistical model is sometimes also fun to use. So we've got 5 minutes left, so I'm going to charge you with 3 calls to action. By this point, if you're sitting at home, I'd like to write everything that 12 calls to action. It's
Probably
a
quite
day, guys. It's a hot light, and I'm sweating loads. But if you were to give 3 concrete calls to action that individuals watching could go do, that would make a measurable, or at least, let's go for measurable, improvement and progress on data diversity, what would your 3 be? Let's go, Harpreet, you go first, because you're always last.
Yeah, no, okay. So
Weren't expecting that way.
No, absolutely not. So I guess 3 for me. Firstly, on the engagement side, so I think try and engage your communities, do events for whether it's your local religious institutions or whatever it might be, but try and engage more with the communities, provide more education. I think that's the first thing. The second is let's start getting more representation of people talking about this from different backgrounds, so that people can relate to each other, they can talk like each other, hear like each other, because I think that's really important, which is the second. And thirdly is let's start collecting those stories, right? How has this benefited patients and their families? Because I think we need to ground this in reality and make it more applicable rather than it just being in the research phase. And I think we need to collect more of those. So those would be my kind of 3 things.
Nice, punchy. Dan. Data Dan. Missing data Dan, present data Dan.
So I'll probably split my first one into 2. So I think what would be really, really nice is if less research was thrown away because it's not in a European population, right? And what I was saying before about the notion that in smaller genetic ancestral groups, we don't necessarily have enough statistical power to do analysis. I think what we end up doing is, if you look at all of these different pieces of research that will be submitted by researchers, and you think about all the little bits of data they're throwing away, if you start putting that together, you could actually start to answer some of the questions that we might want to ask. And I think it's important to consider that, the role of the publishers in this as well. And we should say, we should give them a call to arms and say, you should start requiring this kind of data, that you should say, if in your analysis pipeline you have discarded people of some ethnic minority or some different genetic ancestral background, you should explain why that is. And if it's not a good enough reason, then, that's the thing. So yeah, one is to try and really reduce the fear factor in working with diverse data, diverse population data. And 2 is to make that more accepted. And then lastly would be around language. So as has been alluded to, genetics has a pretty checkered past when it comes to eugenics and the like. And unfortunately, to this day, genetics is still used to further racist agendas. And I think that we have a responsibility as a genetics company and as geneticists or scientists or people in the field to really clarify exactly what we mean when we say something. So to explain why I say ethnicity or why I say genetic ancestry and what the difference might be between the 2. And I think that not only do we need to decide that within ourselves, as a community, we also need to then communicate that more widely so that we can't be misunderstood, so that our research can't be used in that way.
I think excellent points. Nature, New England Journal, Lancet, we're on to you. Natalie, go ahead.
Thanks. So my first point would be around the inclusion and involvement and engagement, as Harpreet alluded to. Don't reinvent the wheel. There's a lot of really good resources out there. There's the NIHR Include framework. There's networks like the Equality and Diversity in Science Network. There's the Data Science for Health Equity.
Oh no, that was my I was going to finish on that. Come on, Natalie.
I'm teeing you up. I'm teeing you up. So basically, there's a lot of existing resources for how to engage, involve different communities. I know we've focused on ethnicity, but of course there's lots of different aspects of diversity. So don't feel that you have to sort of start from scratch if you're exploring new issues around inclusion, involvement, and engagement. Secondly, for those who are responsible for budgets and for staff capacity, resource this stuff and allow people the time and the capacity to ask questions, to be curious. There's so much literature exploring these kinds of questions. There's Superior by Angela Saini, there's Race by Rua Benjamin, there's Invisible Women, Caroline Criado Perez. No, a lot of women and people of colour writing these books. But there's a lot of reading. And if you're curious about this and you have the capacity to explore some of these questions, and I do think that those who are responsible for budgets need to take this into account as well, that actually it takes time. You shouldn't be only exploring these questions on a sort of voluntary basis. This should be sort of built into the way you're working. So that sort of be curious and resource it. And then thirdly, I guess don't make the perfect the enemy of the good. I think it's very easy, as I said earlier, to sort of get stuck and a bit paralysed and not quite know what to do here, but small incremental steps to be curious, to raise awareness of maybe where there might be biases or assumptions that go into data and the analysis of that are steps in the right direction. And the fact is there's not going to be a clear-cut answer to how to do diversity well. It's just not something that's going to have a neat solution. So small incremental steps are beneficial.
Perfect. And I think on that note about kind of reading and consuming and educating yourself and getting out there, as a program, we bosh through a lot of videos and books and articles. Some of them academic, some of them quite light and jovial, but we are going to be releasing our resource list very soon. Last but not least, Sofiane, succinctly.
So one concept that I came across recently was like reference genomics. Now that is, for example, for ethnic, religious, sexual minorities, if we do reference genomics, which means we take like a clan, a group, a body of people, and then have their kind of knowledge about their genetic history and makeup, and then do the same with another clan or group of people within the same community, and then kind of communicate those kind of health benefits and kind of ill health factors to those people. That can be a kind of good way to communicate with those people who generally are at the margins of this kind of debates. The other second thing is young people, and I am kind of realizing it more and more since past 4 years. I've been working with children and young people, and it has to be part, genes and health, the information on genes and health has to be part of school education, or where children are growing up and then they are about to end their teenage and going to start a kind of adult life. So we need to go to those children, young people, and talk more about genes and health and sensitivity related to this. And I mean, we are asking a big chunk of money from Wellcome Trust to help us do that. Thank you very much. Yeah, Don, my director, will sorted you here, and I need promotion for that. Now, the third thing is that when we're trying to help communities through the beautiful, powerful knowledge of genes, let's not blame communities and families and ethnicities because that is counterproductive. And instead of relating it back to the cultural practices, let's look at kind of different variables that affect people's health and make them choose. Social class in Britain is a big theme that needs to be related in this broader debate of genes and health and how we basically explain to people about the benefits or consequences of certain choices they make in daily life.
Amazing.
I will shut up here.
No, perfect. I'm getting told that we need to close because we just had such a stimulating discussion that people are just overwhelmed with how interesting it is, and Harpreet needs to catch a train. But anyway, thank you so much for listening. Thank you so much for joining for the whole day or just our session. And we will hopefully see you soon. Our door is always open at the Diversity Data Programme. We are still early days. Most of the questions were raised were really knotty, complicated and horrible ones. And so we look forward to answering those with you because we recognise this is not an easy thing to solve. Thanks very much for listening.